Hi, today I'm going to demonstrate and explain how to do the manual removal of placenta. This procedure has to be done in an operation theater under the aseptic technique and under the anesthesia, which is either general anesthesia or the spinal or epidural or combined spinal epidural anesthesia. If the patient is already on an epidural, then she can be topped up with the epidural anesthesia. If not, she can be given the general anesthesia or the spinal anesthesia. So the procedure manual removal of placenta is done when the placenta is not delivered in 30 minutes, within 30 minutes of active test stage management. If you are the physiological test stage management, then it will be 1 hour. So in 30 minutes you wait, if the placenta hasn't delivered, then you need to do the manual removal of placenta. It shouldn't be done in a labor room because it is going to be comfortable and painful for the patient, and it's not the proper place. So before the MRB, you must make sure the placenta separation signs are not there, so that placenta is not separated. So before you start in the operation theater, you have to wear the first of all get the proper informed consent, written one. Then after that, you have to wear the surgical gown and have to wash. Patient are in a dorsal lithotomy position, then drape and clean. Then after all finished, only you can proceed that this manual removal of placenta. But right, the glove has to be up to the elbow, so that when you are wearing after you wear the surgical gown, you wear the elbow glove up to the elbow, so that it will cover the whole forehand, because the whole hand will be inside the female genital tract, in the uterus and in the vagina. But currently I don't have the elbow length, so I'm just wearing the normal glove, surgical glove. Okay, so this is going to be the umbilical cord. This one is the sponge forceps. So this is the end. So the baby will be having the same part of the umbilical cord. So this is the umbilical cord with the placenta inside. So when you are about to do it, of course it will be this way. Then you must make sure again before you start the procedure, is there any placenta separated or not. So you have to put your fingers inside the vagina. You have to find the placenta there, and then the fundus will be at the uterus will be at the fundus umbilical area, because the baby is already delivered. And then make sure the IV antibiotic and IV 40 unit acetylsalicylate infusions are ready. So before you start, you have to follow the hand. You have to put your hands follow the umbilical cord up to the cervical os and into the uterus. So os must be open. If not open, you cannot proceed this procedure. So okay, then you have to first go in. Then when you are go up in the cervical os area, your hand has to be at the cone like this kind of thing, so that you can put your all 5 fingers into the os, introduce into the os, through the os into the uterine cavity. The moment your fingers are in the uterine cavity, you can open your hands and you have to try to find the placenta. So first you go inside, and this is your right hand. If your dominant hand is left hand, you put on your left hand is here. So right hand, your left hand, it has to be at the fundus area, so that you know that your hands, this hand inside the hand and then outside one, you know where your uterus is, and then you are trying to prevent the uterine perforation by iatrogenically. So you just follow the cord until you reach to the inside the uterus, and then you find the placenta. So the moment you find the placenta, your hand has to be always at the fundus area. The moment you find the placenta, you have to use the ulnar border, or that you have to use the finger, tip of the finger, to separate the placenta from the endometrial uterine cavity. So you have to find it, and then you separate it, and then you make sure the placenta is all separated. Then only you pull it. You don't deliver the placenta with the chunk by chunk, so it's not the ideal way. So after you separate it already, then you have to pull the placenta. The hand has to be at the fundus, which is at the umbilicus area. Then you have to pull it. And then when you see the placenta at the vulva area, you can use the twisted motion. Twisted motion means that you try to twist the placenta. Okay. You have to do this way. You can put it as a twisted motion in a. Okay. Then it will be. You can see that this is a maternal. This is the fetal surface. This one is a. Okay. This one is a maternal surface. So if this one is inside the maternal uterus, what you have to do is you have to follow the cord, and then with this way, and the moment you are inside the uterus, you can open the hands and you have to find the placenta. The moment you find the placenta, so you have to use a tip of finger or you can use an ulnar border. You try to separate the placenta from the maternal endometrium. The moment all the separated confirm, then only you hold the placenta, you grab it as a whole, you pull it. The hand is at the fundus area, until you reach the placenta is at the perineum. Then you twist that motion and then you deliver. So after you deliver, you have to check the placenta, the cotyledon, is it all complete or not? If not complete, that means some piece of the cotyledon will be left inside. And then membrane, you have membrane also, it has to be, when you pull up, there will be the two membrane, amnio and chorion. It has to be there, or only one hole where the baby is coming. The rest are not going to be, there shouldn't be any hole at all. Then after that, you make sure the uterus is contracted. There shouldn't be itony or anything. So you make sure you uterus massage, and then you start the IV 40 unit oxytocin infusion. And then give the IV antibiotic to the mother, because you put the whole hand introduced into the endometrium, uterine cavity. So there might be the chance of the endometritis. So you must make sure the antibiotic is given. Then make sure the PPH is not happening. So if there is a PPH, yes, you have to continue with the PPH management. Then after that, there might be the episiotomy wound, or there might be the perineal wound tear. So you have to suture it. Then after that, only you finish the whole procedure, and then you put it in a documentation, and then you explain to the patients. Okay, that's all.